Bismillahir Rahmanir Rahim. Assalamu alaikum. I am Professor Adam Ahmed Adam. You are welcome to this parasitology lecture. It is about amoebiasis. It is caused by the protozoan parasite Intestinal histolytica. Clinically, amoebiasis is classified into two types, intestinal and extraintestinal. Intestinal amoebiasis includes amoebic dysentery and amoeboma. In extraintestinal amoebiasis, we are going to find amoebic liver abscess, amoebic lung abscess, amoebic brain abscess, and cutaneous amoebiasis. Intestinal amoebiasis. The infective stage is the quadrinucleate or tetranucleate. They are the same. Quadrinucleate cyst, that is to say cyst with 4 nuclei, as you see in the upper figure. The pathogenic stage is the trophozoite. The sources of infection are humans, cyst passers, people who pass cyst in their stool, being carriers or patients. Regarding disease spread in the community, carriers are more dangerous than the patients. Also, amoebiasis had been reported in non-human primates such as chimpanzees and baboons. The route of infection is the fecal-oral route through one or more of the 5 Fs. The infectious dose is more than 1,000 cysts. Vehicles of mechanical transport of gastrointestinal infections, the 5 Fs: 1 fingers, 2 flies, 3 foods, 4 fluids, and 5 fomites. Fomites are the inanimate objects that, if contaminated, may lead to infection. Now you can see the pictures. Amoebic dysentery. The term dysentery means bloody diarrhea. It is an acute disease. The site of the disease is the large intestine. This figure demonstrates the life cycle of Intestinal histolytica. We start from number 1. Here, the infection takes place by swallowing of the mature infectious cyst, the quadrinucleate cyst. The cyst exists in the small intestine, releasing trophozoites that reach the large intestine. They invade the large intestinal mucosa. They multiply by binary fission. They feed on the mucosal contents in addition to red blood cells. They form ulcers. This is an ulcer, flask-shaped ulcer. When the conditions become unfavorable for the trophozoites, some of them transform into immature cysts. Then cysts and trophozoites are excreted in stool. Trophozoites die shortly in minutes after excretion. They cannot survive in the environment. But the immature cysts with single or double nuclei, they are not infectious, but they mature in the environment to become mature cysts, quadrinucleate cysts that are infectious. Number 7 here, in the large intestine, some trophozoites invade blood vessels and carried in blood to extraintestinal organs, liver, lungs, and brain, forming abscesses. Clinical manifestations. The incubation period ranges between 2 to 4 weeks. About 90% of infected people are asymptomatic. The patient typically presents with abdominal pain, tenesmus, that is a urgent, painful, and unsuccessful attempt to defecate. There will be a small volume of feces and mucoid bloody diarrhea, which is dysentery. Diagnosis, clinical assessment, then stool examination, microscopic examination, and stool antigen test. In stool antigen test, the aim is to detect the antigens of the Entamoeba histolytica in stool. Parasitological investigations, the stool is to be examined within the first hour of collection so as to find alive motile trophozoites, otherwise to be preserved in polyvinyl alcohol. Macroscopically, the stool contains mucus and blood. The pH of the stool is acidic in reaction. This is in contrast to the reaction of the stool in bacillary dysentery, which is a bacterial disease caused by Shigella. In Shigella, the pH is alkaline. Microscopic examination of the stool, there will be high number of pus cells and red blood cells. Trophozoites are found in the aerial stool only. Cysts are found in both the aerial and formed stool. To ascertain, to make sure that the disease is amoebic dysentery, pathogenic trophozoites, that is to say with ingested red blood cells, have to be detected in the aerial stool. The prognosis, the outcome of untreated patients. About 90% of patients recover completely within 3 to 7 days. Some of them may be chronic carriers, cyst passers. The condition may also become fulminant amoebic dysentery, which may be fatal. Perforation of the colon may occur, that can be fatal. Amoeboma may result, which is a mass in the colon. And extraintestinal amoebiasis. Treatment of patients with clinical disease, the aim is to kill the trophozoites by the drugs metronidazole, this is the first choice, or tinidazole, that is the second choice. Also, treatment of cyst passers to stop disease spread in the community. The aim is to kill the cyst in intestinal lumen by the drugs paromomycin, iodoquinol, or diloxanide furoate. Amoeboma. It is a mass of granulated tissue due to chronic infection by Entamoeba histolytica. A mass of granulation tissues due to chronic infection by Entamoeba histolytica. It is found mainly in the cecum and ascending colon. It can be misdiagnosed clinically as carcinoma, tuberculosis, Crohn's disease, non-Hodgkin lymphoma, and maybe other masses. Diagnosis by histopathological finding in a biopsy. Treatment by metronidazole to kill the trophozoites and paromomycin to kill the cyst. Prevention for the whole amoebiasis. Improvement of personal and environmental hygiene, provision of safe water for drinking and other domestic use, foods and fluids heating at a temperature 50 to 56 degrees Celsius. The fluids may be water, milk, and others. Filtration of water, the filters retain the cyst. Washing vegetables in clean running water. Treatment of cyst passers so as to stop the disease spread. Nota bene, that's to say, I'd like to draw your attention here that water chlorination that kills enteric bacteria does not kill Entamoeba histolytica cysts. Prevention here also, this is a figurative demonstration of the preventive measures. Hand washing, flies fighting, safe water supply, prohibition of defecation in open spaces, and safe disposal of excreta. By this, the lecture is over. I hope that it is understandable and I wish you all the best.